So in the next slide, we're going to talk about debriefing, and this is really important, and it can be quite a hard subject. And I say I popped on here like sensitive. I think some people who have maybe not seen a crash before when it's happened, it can be really overwhelming, especially if we've done something like crack a chest open. And again, I think veterinary as a whole, we are very at risk of like compassion fatigue, burnout. So I think when we're doing debriefing, we really have to come from a sense of being sensitive about it, and also being constructive about our sort of feedback as a team. And what we're going to discuss, things like what went well, we intubated that patient really quickly. Oh, lovely. What could have been better? Or perhaps, they should have been I couldn't find the tie in the drawer or in the crash. It wasn't visible, the tie, so I had to go, and I knew where the tie was, but that could have been better. Rather than asking someone to go get me tie, we could have had tie that was already in the crash box or trolley. And maybe we have things like we should have nominated someone as a lead quicker, or things like that, or perhaps it wasn't clear who was leading the crash, things like that. So by doing more team training within your teams, you can tweak these little things that you notice in the debrief and make yourself feel better about the CPR that you do perform on your patients. And also, like, how do we feel it went overall? And I think we obviously know about, we have a civil culture, we don't do incivility, and we're not going to blame, we're not going to be like, oh, you didn't, do this okay. And I think there's a really good example, if you do the Recover course, the basic and advanced life support, they do talk about sort of when they debrief, maybe someone says something that does sound a little bit like, oh, like not blamey, but oh, I'm glad you didn't. Well, I think the examples are, I'm glad you didn't give the atropine over adrenaline, and they sort of talk about letting the silence linger. And I think gives that chance for that person who said that, like, oh, but that's why you did really good closed loop communication, because we all spotted that you weren't meant to give that. You picked up the wrong drug, or you said you were giving the wrong drug, sort of thing. So I think, as I said, we want to make our CPR as the best it can be as a team, as a practice, or as a hospital. And that's the aim of the Recover course and the guidelines. And that's what they've dedicated and put this, so much information. It's so great that we have this. So I think, really careful about how we talk about our debrief and making sure it is a positive. And sometimes I've had cases when people don't want to talk about the debrief there and then, but it is maybe better to talk about it sooner rather than later. But again, if people feel very emotional about it, sometimes it isn't helpful just to, talk about it there and then, and they're really upset. And again, looking for support, external support for those people who need it as well. So if we have, a child, got a patient who's survived, and we have achieved ROSC, again, we know it's a low survival to discharge rate for these patients. They're likely to rearrest, and they've often got like a really nasty underlying systemic disease going on, unless it's something, iatrogenic anesthetic related. And there's a really nice algorithm on the part of the Recover guidelines about post-arrest care, and looking at whether our patient needs to be ventilated. Most of the time I find that they are delayed. We don't have we have to ventilate them by hand for a bit, and maybe sometimes the owner's already made their decision that they would like to euthanize, or they've gone back into rearresting again. Maybe we have to think about whether they need a ventilator if they can't breathe by themselves. One thing I suppose I forgot to mention during CPR, you can, if you have the ability to check blood gases during CPR, that is ideal. I know not everywhere has that. So again, our bread and butter is making sure we do correct, efficient chest compressions, and we're ventilating our patient. And we're thinking about those sort of maybe there's drug therapies every other cycle, but ideally be nice to have an idea of a blood gas of how acidic your patient is, and whether you reach for things like sodium bicarb. But in post-arrest care, you would like to be monitoring those patients quite closely, those electrolytes, those lactate, those glucose, and keeping a little beady eye on their ECG, blood pressure, making sure whether we have to think about, as I popped on there, like noradrenaline, dobutamine, so like norepinephrine, obviously looking at a positive like inotropes when sort of vasoconstrict, and dobutamine will help with cardiac contractility. So obviously the heart's been, had CPR, maybe it'll be very sad, probably it's got poor contractility. We have to think about things like dobutamine would help improve that contractility. I put hypothermia on there, so if our patient, there is examples of using cryotherapy in patients to prevent like cell death within sort of their brain, things like that. So, to prevent any further brain injury due to hypoxic injury, and sort of giving prophylactic mannitol or anticonvulsants as well. And without saying, obviously, analgesia to these patients because they've had, cracked ribs or they've had their chest opened, and it's been very, very sore, very painful. But the Agarum's a very nice one. And again, be careful about our fluid therapy. Perhaps these patients do need fluid therapy, or perhaps they need a blood product if they've like hemorrhaged or lost a lot of blood. And again, talk about teamwork. So recover training, really recommend that for your teams, and it's really worthwhile, and it's a great course. And again, there's lots of opportunities I think out there as well to do recover training like in real life with certain CPD providers as well, and we do it here on clinics at Langford for the students and for our staff. So yeah, really important. We do ours like once a month. And it really helps everybody feel on board with what we do in a crash situation, and no one's left thinking, oh my goodness, what do I do like now? And the Recover app that they've got on there, it's really nice. Popped up there, okay, to install. But yeah, it has a metronome, has the breath noises, whether you like those or not. I've turned mine off. And yeah, really helpful to have that like good metronome noise. And leadership training, I popped on their team steps. So they are trying to make a veterinary one at the moment, but it really talks about like, because leadership I think is quite hard in veterinary. I think we do so much emotional investment in our cases, and it can be actually exhausting. We have like, I feel like we've got, you get fatigued making all the decisions, or you have teaching fatigue sort of thing, teaching people all the time. So I think having anything to have tools to help you work better as a team, or have some leadership training, really will help. But yeah, the Recover Guidelines update is available, so it might be have a little worthwhile taking a look at. And the things they look at are sort of like making sure there's clear communication, as we talked about, closed loop communication, making sure the person who's leading the crash or like running the code is sort of like they make themselves like known quite quickly. So they have to sort of declare themselves as leading the crash. They then say, oh, yeah, you'll get a person doing compressions, a ventilator, drug handler, or recorder. And again, if there's other people, if you're lucky enough to have other people around that you can assign, getting things like extra bits of flush or whatever that's not maybe in your crash box, or person that's stood there ready to rotate to do chest compression, because obviously it is hard work doing chest compressions. And the person who is running the crash, I'd say they are sort of the sort of end point in decision making. They're not trying to do a dictatorship. That's not the idea of them. It's meant to help everything flow, be efficient and concise as possible, and be concise in decision making of like, when we get to this 2-minute pause, is this patient in a non-shockable or shockable rhythm? And if we're not able to make a decision, the person who's leading the crash will make the decision. And also the leader's job is then acknowledge input from the team members. So if they're suggesting, oh, let's take a blood gas now, like, okay, yeah, make sure you acknowledge that and be like, yeah, let's take a blood gas, that's a good idea. Or perhaps after this 2-minute cycle, we'll take a blood gas then. Thank you, like, great idea. So I think that really helps make people want to put their ideas forward, and working as a team makes it nicer. And what do we have in our crash box trolley? Obviously, we're very lucky, as I said, we've got a nice crash trolley, but we have various sizes of ET tubes, again, for all range of big, small, tiny animals. An ambi bag, again, really recommend investing in an ambi bag that you have connect to your flow regulator, and you just plug into your piped oxygen. And having a stylet as well for those like brachy patients who've got a lot of soft tissue in their upper airway. And again, a UCAS if you need to then put drugs down the ET tube. Also, having UCAS to help as a stylet, it really helpful too. You want some bandage in there to tie your ET tube with, cuff puff. Again, some patients might regurgitate during CPR. We don't want, if we've got a chance of getting this patient back, we don't want to have that aspirated or that gunk. Again, having suction units and things like that is really handy. And IV access, we have a little drawer for different types of catheters available, as well as obviously very lucky to have our EZ-IO in there too. We have capnograph on our trolley. In our trolley, we have a direct monitoring one, or you can use the side streams one. But again, if you say you're in your prep room or something, you want your capnograph to be nearby in a place where you are going to be doing CPR. And thinking about drug therapies you would have in your crash trolley, so things like glucose, in case your patient's like hypoglycemic, obviously reversal agents. I pop propofol on there just if you've got a patient in respiratory arrest. So obviously it feels really counter sort of like productive, like trying to anaesthetize a patient that's maybe going to go into respiratory arrest, but we need to be able to take control of that airway. So by giving them an induction agent to be able to then intubate them safely and be able to then perfuse them and start CPR, because sometimes you get cats or like brachycephalics going into respiratory arrest and they're already like quite aware, but they won't let you intubate them, and the propofol comes in quite handy for that. So it's really important just to try and take control of that airway. Again, atropine, epinephrine, adrenaline, lidocaine, amiodarone, and esmolol as per recover guidelines on there, and some syringes and needles. And we try and replace the syringes and needles and things like every month, just so they're not going to be super duper like sterile, being there a month or whatever, but again, it's just making sure they're fresh. And we've rechecked our crash trolley, and we have tags in our crash trolley. So if you think we want to know if someone's broached your crash trolley, because the worst thing is you get there and you're like, oh, someone's taken the laryngoscope. So tag it as best you can and make sure people can't like wheedle their way in between the tags. Are there for a reason, for really important. Obviously you're checking it every month anyway, but it's just important that people, if they are taking something, they replace it or they retag it. And again, we have our surgery kit for open CPR, as well as our defibrillator and suction units. There's our little pictures there of our setups in our trolley as well, maybe to give you some ideas. And obviously yours may not be as as big as this one, but again, just a little looky-loo. And again, we've got some drapes if we want to do for the open chest CPR, and we have got some paddles there. So those are internal defibrillator paddles as well for those cases. And this is the algorithm. Obviously it's not a draft anymore because this is now up and running and on the go, but it's quite a nice algorithm to have a look at, and definitely recommend it. It's a free access article on Wiley and Blackwell, the recover guidelines as well. So really recommend looking at that. And now you also can download the the algorithms and the drug doses and things like that. So just to bear in mind, the updates are, if you are you're already savvy with the historical recover guidelines, that we are changing the 2 hand compressions for small animals, removal of high dose adrenaline, again, no difference between vasopressin and epinephrine, atropine only to be given once, and only double charging the defibrillator kilojoules once and staying at that charge if we are refractory, and adding in the esmolol if we are refractory to defibrillation. And I think with the new algorithm, it is a bit more in detail of what next steps to take, and the new post-arrest algorithms in the works, and the new neonate guidelines is out now. So thank you for listening to me today. But yes, it's lovely to speak to you guys, and I hope you enjoyed it.